Hello, everybody. So we have done a lot of training on pit crew CPR, a lot of training which is likely to result in more Rosc. But Rosc is a fickle thing. So what do we do when we get Rosc? Our objectives are to identify signs associated with Rosc. We're going to review a Rosc checklist that should be located next to the defibrillation pads in each monitor. And we're going to discuss how to manage the blood pressure after Rosc, and we're going to discuss exactly what we do with a patient who has achieved Rosc. So first and foremost, always plan for Rosc. Expect Rosc. You will get Rosc, and we need to plan for Rosc before we actually get it. There are multiple signs that are associated with Rosc, and these can clue you in that the patient that you are performing CPR on has Rosc. The first and probably the most important is that you should see a significant increase in end-tidal CO2, which is defined about 10 or 15 more than you were at. So you know that if you're performing CPR on a patient and the end-tidal is less than 10, then that's associated with poor prognostication. So you're not likely to achieve Rosc on that patient. But if the end-tidal CO2 is above 20, then that patient is more likely to achieve Rosc. So if you have an end-tidal of about 22 or 24, then suddenly it jumps up to 35 or 40 or even 50, then there's a good chance that that patient has Rosc. Now, it doesn't always mean that they have Rosc. It could just be that whoever was performing CPR was doing very poor quality CPR, therefore the end-tidal was low. And then they rotated and somebody was performing high quality CPR and the end-tidal CO2 has increased. Just because you see that increase doesn't mean that you should stop CPR and check for a pulse. It's always good to go to the end of the cycle and then check for Rosc. Also, if you have an organized rhythm that's greater than 30 beats a minute, meaning not VF and not asystole, then there's a good chance that that patient possibly has Rosc. So you know that you won't have Rosc if the patient has asystole or VF. Now, it is possible if they have an LVAD, but very unlikely that we're going to be routinely performing CPR on patients with LVADs. So when you're performing your pulse check, do we really have to check for a pulse with these rhythms? The answer is no. So if you've got your finger on the pulse, it's a minute 45, someone's got their finger on the pulse, and you reach 2 minutes, you switch your compressors, there's really no need in delaying hands-off time to feel for a pulse when they have these rhythms. So we have a pulse, now what? All right, so let's focus on the post-Rosc checklist right there. So first and foremost, we want to ensure that somebody is talking to the family, explaining to the family what is going on. Assess CO2, so you should expect end-tidal CO2 greater than 20. Make sure the airway is patent, and keep your finger on the pulse. I cannot stress this enough. Remember, Rosc is very fickle, and the patient is likely to re-arrest within the first 10 minutes. So dedicate a person, doesn't matter who, to locating the pulse and keeping their finger there. And you always want to have the monitor within view. So you should essentially, if somebody's finger is on the pulse and they can view the monitor, if that patient were to go into VF, there should be no longer than a few seconds worth of delay before somebody is back on the chest performing CPR. It's also good to keep a finger on the pulse and eyes on the monitor to watch for the patient to go bradycardic, because it's generally they're tachycardic, then the rate starts slowing before they re-arrest, and we catch it when it's too late. Keep the pulse ox, the SpO2 at least 94%, not 100%, because if the SpO2 is 100%, then the arterial oxygen concentration could be anything. We don't know what it is. Don't hyperventilate to try to normalize the end-tidal CO2. Every time you squeeze the bag aggressively, you increase intrathoracic pressure, and that patient with a failing heart is going to have a harder time maintaining cardiac output. Get a 12 lead, get a 12 lead, get a 12 lead. right? There's a good chance that that patient that went into cardiac arrest suddenly is having a big STEMI. So we want to get that 12 lead, and if it's a STEMI, expedite them in a controlled fashion. There should be no rush because you don't want to miss anything. Assess and treat bradycardias aggressively. Treat them before they happen. Pre-mix your pressor. Get your pressor ready to go, hung, line spiked, maybe even connected, right, but clamped off. Anytime that patient starts to become bradycardic, or if the systolic blood pressure is less than 90, start it. Get the pressor going, prevent rearrests. Continuously monitor airway placement. And if the Lucas is not on, it's a good time to have the Lucas on, just to place it for in the event of a rearrest. We've got a pulse back. We've obtained a 12 lead. Does the patient need PCI? Well, this was a study, and the conclusion is that the results of this systematic review demonstrate that nearly one-third of patients who have been successfully resuscitated from cardiopulmonary arrest without ST elevation on ECG have an acute lesion that would benefit from emergent PCI. So 1/3 of patients without ST elevation after cardiac arrest will benefit. So ST elevation can also be fleeting. So if you get a pulse back and you obtain a 12 lead EKG, there's a good chance that you will find ST elevation, but that the ST elevation might be transient. Post Rosc 12 leads are very complicated, okay, because the heart's been ischemic for some time. It's been deprived of oxygen and other nutrients. So you're likely to see any number of changes. So you want to get a 12 lead, and within about 10 minutes, you want to get another 12 lead and look for changes because the EKG frequently normalizes. But in any event, if you get a pulse back and the patient arrested suddenly, if they have a good story, so if they clutch their chest and suddenly went into cardiac arrest, there's really a good chance that that patient needs PCI. Here's a pretty good algorithm that was released from the American Journal of Cardiology in 2015 that kind of helps us and more so the hospital determine who needs emergent PCI. So there are right here, you can see unfavorable resuscitation features. So if it was unwitnessed, if the rhythm was anything other than VF, if they didn't get bystander CPR, if it took more than 30 minutes to get Rosc, etc., etc. So those are patients that the hospital is less likely to cath emergently. So we need to know who they are more likely to cath emergently. And a lot of times, if you call in a radio report with a compelling story and a compelling history, they may just take the patient immediately to PCI. I was recently involved in a cardiac arrest where within 2 shocks, the patient obtained a pulse, and we called ahead to the emergency department and spoke to the ED physician and said, here's a patient with a compelling story, witnessed shockable rhythm, was down less than 5 or 6 minutes. Would you want to cath this patient now? Or rather, would the cardiologist? I asked, do you think the cardiologist would rather cath this patient now or later? And he said, I will go ahead and call them. So always prepare for rearrest. Again, keep a finger on the pulse. Aggressively manage hypotension, which means a blood pressure less than 90 systolic, and this is an American Heart Association recommendation. So get your pressor ready. Don't care what it is. If your preference is dopamine, if you're more comfortable with dopamine, then do that. If you're more comfortable with epi, then do that. Now, we have it now in our protocols to administer an epi drip. Technically, it's always been for a long time, it's been in the AJ guidelines to give dopamine or an epi drip. Now, how do we do that? The easiest way to mix an epi drip, especially if you already have fluids going, is to take 1 milligram of epi. Doesn't really matter the concentration. If you do 1 milligram in 10 mLs, which is the 1 to 10,000 concentration, that extra 10 mLs is negligible when it comes to calculating your dose and your rate. But look at this. So if you take a milligram of epi, you put it in a liter bag, there's 1,000 milliliters in a liter, okay, of fluid. And then if you take a milligram of epi, there's 1,000 micrograms of epi in a milligram. Doesn't matter if your milligram is in 10 mLs, there's still 1,000 micrograms in 10 mLs. Okay, if you mix 1,000 mics in 1,000 milliliters, your concentration is 1 microgram per ml. So if we don't have liter bags, or if you haven't hung a liter bag and you've got a 500 cc bag right there, you can still take that milligram of epi or that 1,000 mics, put it in 500 cc's. Then instead of the concentration being 1 mic per ml, your concentration is now 2 mics per ml. And you know that a 10 drop set, being 10 drops equals 1 ml, if you give 1 ml, you're given 2 micrograms. Okay? Conversely, if you're using a liter bag, 1 mic equals 1 ml, or 1 ml equals 1 mic. So if you give 10 drops, you're giving 1 ml, therefore you're giving 1 microgram. Label, label, and label. Take a piece of tape, keep a Sharpie in your pocket, and label everything. You don't want someone thinking that your now dirty epi drip is just fluid and bolus the patient with a whole lot of epi. Even though with a dirty epi drip, it's a very, very dilute concentration, so it's not very concentrated. If you think that typically if the hospital's starting an epi drip or even a norepi drip, they usually take 4 milligrams and put it into 250 ml, so that's very concentrated. Ours is very dilute. We have 1,000 mics or a milligram in a liter. So in summary, with perfect CPR, we're going to have Rosc more often. It will be a more common event. Also, we're having longer scene times, okay? So those patients that we were scooping up and running and trying to get to the hospital, we're going to be seeing more Rosc in the field as opposed to in the hospital, which will allow us to transport those patients to the appropriate facility. Prepare for Rosc, use the checklist, aggressively manage hypotension and bradycardia. Rearrest is most common within 10 minutes. So the first 10 minutes of Rosc are essential. Be prepared for rearrest. Transport to a PCI center. I'm still waiting on their criteria for for taking a patient to PCI post Rosc, and once they give that to me, once the different hospitals give that to me, I will send it to you. And keep a finger on the pulse. As always, if you have any questions, feel free to let me know, and thank you for providing quality care to the citizens of Jessamine County.